I'm really excited about this panel. The last panel focused on, sort of vertical power and insurers owning physician groups and other parts of the supply chain when it comes to medical services. This panel is going to focus on corporate influence in medicine, which is sort of, I think, kind of the other side of that coin in some respects. And we have a kind of an amazing, we have an amazing group panel here. And I'm just going to really quickly introduce everyone and then jump right in. Lauren Adler is a fellow and associate director at the Brookings Schaefer Initiative on Health Policy. His research focuses on a range of topics in healthcare economics and policy, including private equity and payer acquisition of physician practices. We've got Hayden Rook, is it Lee or Lay?
Lay.
Hayden Rook Lay is a judicial law clerk and former senior policy analyst. His expertise includes Medicare Shared Savings Program and other primary care-based alternative payment models. Also has experience as healthcare staffer on Capitol Hill. Dr. Mitch Lee is Chief Medical Officer of the American Academy of Emergency Medicine, also the founder of Thrive Direct Care, which is predicated on direct primary care model and providing transparent access to emergency physician without the need for insurance. Dr. Marco Fernandez is president of Midwest Anesthesia Partners, and his focus involves on using behavioral economics and analytics to navigate quality care in today's healthcare landscape. And last but not least, Eileen Applebaum is co-director of the Center for Economic and Policy Research. Her current research examines implications of consolidation on hospitals and decentralization of health services, and in many ways is kind of pioneered research on and criticism of private equity's influence, not just in healthcare, but other industries as well. And I want to jump right in to the question here. And, after hearing the previous comments today, perhaps the most concerning issue with market power in healthcare is patients can't really trust that doctors are making decisions based on their medical judgment. Rather, we're often seeing doctors make medical decisions based on financial incentive and pressure. And I want to ask the panel, which markets, which companies, which types of companies are you most concerned about when it comes to the problem of corporate influence in medicine? And why don't we kick things off with Eileen here?
So my big concern now is the capitated payments. They call them value-based payments, but basically the provider or the provider organization, it's not necessarily the clinician that gets the money, but a provider organization gets a flat fee for the patient for the year, and whatever they do not spend on the patient, they get to keep. So it does not seem like it seems like a formula for easy disaster or easy cheating. What we have found is in the nonprofit world, largely, it works as advertised. And in fact, the capitated payments, for example, in hospice, were introduced when there were no for-profit, almost no for-profit hospices. And you did see them take the capitated payment, take the money, figure out how to spend it on social workers and nurses and whatever things they need to make the service better. And you know that they were doing it because the net operating budget that they had, income that they had out of it, was frequently 3% or 4%, most recently 6%, but not higher than that. And when the for-profits came in, their operating net income is 19%, pretty much every year. So we have to think, what is it they are not providing? And in the case of hospice, we know a lot of things. In hospice, you only have to send a nurse to see the patient once every 14 days. None of the nonprofits that we spoke to do it once every 14 days. They have at least once a week. The nonprofits have somebody come in.
None of the nonprofits.
They do more is what I might have said it backwards. The nonprofits do a lot more, a minimum of once a week, and as the patient approaches death, often more than that. They send out emergency nurses after hours. If somebody calls and says the patient is in distress, they will send that person out. For the dementia patients, they often have music therapy, for example. because one of the things that they found is that the dementia patients can't talk to you, they can't tell you anything, but if you play the songs that they need, they will sing them. And this is really very, very good for the family to see that patient for some period of time in their normal self, so to speak. So those are the services that are provided. You can see that it works. But once you introduce private equity, or actually any for-profit, they get to keep whatever they don't spend on the patient. And I'm sure we can all think of the many things that they can do not to spend on the patient. And one is to restrict the visits, not to have the after-hours visits, not to have the extras like music therapy that's not required. Many things that they can do to cut costs and to increase their net income. And that is what they do. That's the easiest one to understand. That's why I always start with the hospice. But similar things are going on in Medicare Advantage. The idea that they're trying to kill Medicare as we know it by having the accountable, what do they call them, the reach? Anyway, they have, where your doctor is part of an organization. You're not signed up anymore. In the Trump version of it, they signed you, the patient, up, and you couldn't go anywhere else. Now, as the patient, you can still go other places, but if you see your regular doctors and they save money on you, they get a kickback at the end. I call it post-capitated pay. I don't want to call those capitated, but those are post-capitated payments, and I think that's the biggest danger right now.
I think as a physician, private equity or for-profit interests are not the only threat to physician autonomy. The way I got involved with all of this was private equity came knocking on our door. I'm the president of a large, organically grown physician anesthesia group out of Chicago, and we lost a couple of contracts to private equity. We were rolled up. We were blindsided. This was at the start of the pandemic. And so we ended up losing a couple of contracts. And more recently, I'm independent and I work for a hospital. We have 37 physicians that work there, and we were terminated in August. And that was partly because we refused to adopt a production model. To me, how does an anesthesiologist produce anything? We're a hospital-based service, and anything that comes in the door we take care of. But because everyone wanted to control us, it wasn't about the money. They decided to go in a different direction. And my burning platform is physician autonomy. And so now we're trying to pivot in our current market to try to figure out how to stay independent. And we're being pushed out of hospitals. When this was all happening, I reached out to Mitch. He educated me, he helped me, and we ended up creating an association for independent medicine. It's a multi-specialty platform to try to help physicians stay independent. We're getting more traction. We're trying to involve more folks across specialties. And from the human side of it, we feel like we're drowning, and it's great to be part of this forum so that people can actually see what's happening with physicians on the ground, and I'm happy to tell our story.
I think that's a great transition for Mitch. And Mitch's report, actually, I want to make sure everyone knows, is out front. If you want to grab a copy, feel free. But Mitch, go ahead.
Thank you. Thanks for having me. I think if you talk to a lot of physicians, you're going to hear, if you listen to them, this sort of human cost, that things aren't right. Everything is too corporatized, and it's all about producing for some other for-profit entity, and it's not what we signed up for. And that's reflected in physician burnout statistics, and right now I think it's 63% for emergency physicians, most recently, which raised after the pandemic. But I would contend that it's not the pandemic, it's not even people refusing vaccines or whatever that has done this, but rather the consolidation and opportunism by private equity and other non-physician large corporations that were looking to take advantage of the situation. So when you speak to all these physicians, we know there's a problem, but very few people are aware of the concept of the corporate practice of medicine and the doctrine and then the legal basis for it. The intro that I had is a little bit outdated. I'm representing the organization Take Medicine Back, which is taking medicine back from corporate interests. The AMA is not here. The AHA is here. AMA now maybe represents like 11% of practicing physicians, is estimated to be. We don't have that much of a voice, and to be honest, a lot of the organized medicine groups have been infiltrated by private or financial interests. So if we look back to the first Gilded Age, where antitrust really started getting its legs or became a thing, emerged. At the same time, physicians were recognizing that maybe being employees of the mining and railroad corporations was not such a good idea, because they could commercialize the practice, they could influence the practice, and the concept of the corporate practice of medicine emerged. This was weakened over the past several decades, along with antitrust law. And now I think we're starting to wake up physicians to say, hey, we thought about this before, and maybe there was something to it. I'm an emergency physician, and I graduated from a residency program that was taken over by Team Health, and then the next year it was taken over by Blackstone. We saw a transition to all of our attendings being worried about this production thing, much less of a focus on our actual learning and education, and mostly they were worried about keeping their jobs and also decreased staffing, that kind of a thing. That residency program, the physicians there just unionized and formed the first union against a private equity-backed contract management group or physician management company, depending how we use terminology there. I learned a lot more about the history of emergency medicine, which turns out there was a exploitative business model that was started in 70s, 80s. It wasn't initially owned by outside interests, but it was owned by some savvy emergency physicians. This is a contract management group model where you had a contract with multiple hospitals and then profited off the labor of your colleagues. But pretty quickly, those were sold to lay interests. There was the corporation out of Canada, Laidlaw, which eventually turned into Onyx, private equity, and then eventually MCare turned into Envision, which is now bankrupt, as you guys are probably pretty aware. That CEO just went to Humana, I believe, so we're kind of heading toward that vertical integration direction. So there was some support of private equity in emergency medicine because the sentiment was that we needed something big to fight the insurance companies that were really the evil ones. So we said, well, let's align ourselves with these private equity guys because they're great. And what we've really seen is, of course, that's a 3 to 7 year model, and they're selling to somebody else, which, if you could read the tea leaves, was probably going to be the insurance companies. And so we look at this as when elephants fight, the grass suffers. The physicians, other healthcare workers, and the patients and the public basically are the grass, while these big behemoths of finance are doing battle. This is sort of the Amazon defense. We needed to, Amy Klobuchar, I believe, called it the Amazon defense. We need to consolidate in order to fight the other big consolidated guys, and so consolidation begets more consolidation. So I'm going to make an appeal to the other panelists, the DOJ, the FTC, and to folks in this room to eliminate the word provider from your lexicon. We heard from the last panel where there was the AHA saying, they're the providers, and then we also had an attorney who represented providers against payers. I'm not sure which providers those are, but I imagine things like Team Health, Envision, which are owned by private equity firms that were suing United Health, which are now all becoming the same thing. But those are not physicians, and those aren't the healthcare workers at the bedside. Those are representing big private equity firms who are in violation of the corporate practice of medicine doctrine. And Maya Miller was on the last panel and did some excellent work with ProPublica. Thank goodness for them. They have distinguished this, showing that private equity-backed groups were suing and garnishing the wages of poor patients during the surprise billing out-of-network disaster that was really driven by private equity firms. If anyone isn't aware, with Doctor-Patient Unity, Doctor-Patient Unity was found to be a dark money group backed by Team Health and Envision primarily, which was Blackstone and KKR. And she also, in ProPublica, demonstrated that it wasn't physicians who are benefiting from these marked up bills, rather it was wealthy investors. What we really see is that physicians don't have transparency in what's billed and collected in our names. The American College of Emergency Physicians, when asked to support the idea that we have transparency, actually said in an analysis, maybe we shouldn't do that because it might leave physicians knowing, and then we'll be liable for the fraud that's being committed in our names. So that's kind of funny. So at this point, the AHA said they represent providers, but they actually oppose the elimination of non-competes that the Federal Trade Commission has put forth, especially for physicians. And this is something that we believe drains communities of actual physician resources because we can't go get a job at the next place over, and we don't have workplace protections so that when we actually advocate for patients, we can be fired on a whim, in particular when the hospitals, which is a large majority of them, contract with third parties like Team Health, Envision, any of these roll-ups, WCAS that's being sued by USAP, U.S. Anesthesia Partners, is being sued by the FTC right now. So I think what's missing from the discussion much of the time is that while there's monopoly power that's built, there's also monopsony power over labor. And as 75% of physicians are employed, we are now labor, and they have more influence over us. And that also means they have more influence over the practice of medicine. So one more aspect of this is provider is conflating us with these big giant institutions. It's also conflating us with non-physician practitioners who we are increasingly being replaced with as another driver of profits. And an example that you might be familiar with is Cerebral. The Department of Justice is suing or investigating Cerebral, an online platform backed by VC, Silicon Valley kind of a startup that was providing like mental health care and like Adderall prescriptions, that kind of thing. If you look, they don't call their clinicians or physicians or even providers. They call them prescribers. CBS News did an investigation and found that of the 1,500 clinicians on the website, 5 of them were actually psychiatrists, and 3/4 of them were nurse practitioners without even any mental health background. They found that there was 15-minute brief appointments, 5 prescriptions of psychiatric medications given to patients within this very brief workup, which is not sufficient even with an expert psychiatrist. One woman had her concerns blown off when she said she was having nightmares about suicide and hanging herself, and then she did attempt suicide and hung herself. So if that's sort of concerning to you, and we look at sort of pharma, PBMs, and insurance companies controlling this care, then I think the vertical integration that we're seeing that private equity has catalyzed is kind of a nightmare situation. You see CVS with Cigna, Aetna, or CVS Caremark, and then you have Minute Clinic, and now they just acquired One Medical. So now you have complete vertical integration and a push to remove physicians from the picture entirely and control the prescribing market. So now you have the PBMs, the insurance companies, the retail, all of it kind of rolled into one, and I'm sure you're going to hear plenty about United Health coming up next. Amazon as well as sort of being the focus of the Federal Trade Commission's central thesis. Really harkens back to the idea that the railroad and mining corporations of the past are coming back, and now they're employing physicians, right? And non-physicians. They're going into that market with One Medical. So I think if we really look at this in a historical context, that should be extremely concerning to people. And finally, there's a little, I'd say that would answer your question. We're worried about this vertical integration roll-up and sort of an extreme of the corporate practice of medicine we've never seen before. I'll stop there for now. Thanks.
Okay. Yeah. We got a lot. We got vertical power, monopsony power, PE, e-health. Hayden, why don't you? I want to keep plying through these problems. We've gone through a lot of them, but we can get to solutions next. But
yeah,
please take it away. Yeah.
A lot has been covered here. Maybe I'll just add, as a general point, I think it's hard to overstate the degree to which the medical industry has been corporatized over the last about 20 years. I think physicians, Mitch mentioned 75% of physicians are now owned by some sort of corporate entity. That's about 50% hospitals, about 25% private equity, and some of these new corporate entities, mostly insurance companies and retailers. Most of that, 20 years ago, most of that was catalyzed by hospitals, and that the vertical integration from hospitals continues to be an issue. Lauren's done a lot of good work on this, particularly showing the purchase of physicians by hospitals leads to, what you might imagine, just greater negotiating leverage in the commercial market, in a given market, and higher prices. Also, fueled by 340B program, site-neutral payments, other Medicare policies. The most recent acceleration we're seeing is from these sort of non-traditional corporate investors, particularly in the last 3 or 4 years. I think about 86% of the increase in physician acquisition is being driven by private equity, but more so by pharmacy retailers and insurance companies. And this gets to the point that Eileen made. I think it's important to recognize what's going on behind the scenes with healthcare policy and our thinking behind basically how we finance our system. There's a consensus around moving towards versions of capitated payments or value-based payments. There's all sorts of buzzwords for it. This is led by Medicare Advantage. I think we need to really think hard about the way that that program, which now is, capitating out hundreds of billions of dollars every year. I would add all our state Medicaid programs as well are now running on a capitated basis where we, have private entities, risk-bearing entities administer the program. We got to think hard about how that might be distorting the provider landscape, to use Mitch's favorite word, and really be concerned about whether the Medicare program is driving a level of vertical consolidation that has a lot of the downstream effects that we might be concerned about.
Awesome. And Lauren,
I'll just sort of tack on quickly. I think sort of just in, the original question, sort of like the factors of how you look for and where you might be more concerned about private equity activity here. I kind of think there's sort of a few areas that characteristics that you might look for in a sort of specialty or in a type of market. I think one is where quality is hard to observe. So I think here in certain aspects of like nursing homes or some behavioral health centers, where it is often not the person who is in the facility making some of the financial decisions involved here. That is, I think, leads to at least some potential avenues. And that is the nursing homes, for instance, is where we do have the sort of strongest evidence of pretty clear consumer harms from this private equity activity. I think another one is just where patients don't choose their clinician, so there's not that sort of standard demand side pull against. All right, if you're talking about primary care or going to your dermatologist, at least there's some demand side. If they're doing really bad quality of care, people will, in theory, stop going to them. But when you're talking about this, emergency medicine, anesthesia, where patients really aren't choosing who their clinician is, that leaves open, I think some areas for higher costs anyway. I don't think we have strong enough evidence on the quality side here. But, and then also where there are sort of clear market failures or perverse incentives to take advantage of. To me, that's largely the surprise billing story, is there was this just pretty clear market failure kind of sitting on the table. It happened to be private equity, but sort of, some of it was publicly traded companies, right? This was kind of sitting there. It's sort of money sitting on the table. Someone's going to take it eventually. So someone did. And I think, that story could be, doctors get paid more for prescribing for injecting a more expensive drug. So this is common for ophthalmologists, where basically you get paid. There's, if you get two competing drugs, but you get paid by Medicare more money to inject the more expensive one, that is, that's a pretty clear incentive that you probably suspect there's going to be some advantage taking there. And then just broadly, right, part of this is just this is one method to fuel consolidation, right? It is an acquirer who has very clearly fueled consolidation in, they saw the USAP, the U.S. Anesthesia Partners complaint, where, in Houston and Dallas, where we have seen sort of massive consolidation. And to Mitchell's point, right, I think that is not only, I think we see higher prices and lower quality in general when that sort of consolidation happens, but it does have the monopsony side of things as well, where when there is sort of one company here that is sort of dominating a market, and if you are, an anesthesiologist who wants to work in Houston, you're kind of, it's sort of near the only game in town is to go work for U.S. Anesthesia Partners nowadays, right? That is going to weaken your bargaining power. And we've seen this in the hospital context as well, where when hospitals are very consolidated, you see nurses tend to get paid lower wages in those sort of markets. So I don't think it's surprising that we would see something similar in emergency medicine and anesthesia markets.
And so we got a lot of problems on the table here. I would like to talk about solutions, particularly as it relates to sort of more enforcement that could happen at the state and federal level. Laws that are not used, or enforcement that's sort of low-hanging fruit, or whatever you see as kind of more enforcement that could be done to tackle some of these problems and present some solutions. We can get to new laws after that, but I really want to stick to sort of laws and authority that's on the books that could be used. Eileen, could you kick us off?
Well, I won't have the most to say about this topic, but one of the things that we do see is that while CMS has a range of punishments or consequences that it can enact, it rarely uses the severe ones. So in the case of hospice, which is the easiest to understand, I think Medicare Advantage is the biggest problem, but the issues are very similar and much more harder to understand in Medicare Advantage. So I always start with hospice, where you can actually understand them. It's easy if they actually do inspections to find evidence of misbehavior, poor care of patients, no care of patients, zombie hospices. California used to be one of the worst, there with Texas and Florida. Now it's Arizona, Texas, and Florida, because California got its act together and passed some legislation that took care of the worst problems. But even with the terrible problems that they had in California, which I won't detail here, Medicare or CMS knew about it, but did not really come in and do anything about it. They may have revoked the certification of 1 or 2 hospices in the entire state when there were hundreds that were a problem. So what they do is, the main thing they do is they make the hospices write a plan of action to correct the problem. There's no financial penalty, we're threatening your license. So it's clear that they have a range of things that they can enforce with, and that they choose not to use them. I really see CMS as a big part of the problem. I don't understand why they've been captured by this view. There is an article in the American Prospect that I highly recommend called Patient Zero, and you can see the deliberate effort by private equity to capture CMS and how they did it. But why they are still captured to this day and do not do even the minimum that they can do, and are trying to force all of us into capitated programs, trying to destroy. They announced it already. They want to destroy regular Medicare as we know it by 2030. They want everybody by 2030 in a capitated program of some kind. So let's just enforce the things that they have. Let them use the tools that they have. Let them close them down, or suspend their ability to admit patients. I did see that the PACE program was so bad that in fact they did suspend the ability to admit patients until certain things were cleared up. They have that ability. They almost never use it.
Yeah, we've actually seen some state enforcement when it comes to I would say, very troubling lack of care, particularly for the elderly, some of these programs with PACE, including PACE. Marco and Mitch, what do you see at the local, you guys are on the ground, the local level as well. What do you think can be done, more enforcement, the laws that are on the books, or for the federal government as well?
When it comes to laws, that's way out of my wheelhouse. I mean, I have enough trouble just being an anesthesiologist. But I think that one of the things that I recognized was the lack of support from our established societies, from the AMA and the ASA, the American Society of Anesthesiologists, and as Mitch talked about, being infiltrated by private equity. When we lost our contract to Team Health, it was spearheaded by the treasurer or a board member from my national society. So here I'm paying dues to someone who's supposed to educate me and protect me, and they're not. And the same goes for the AMA. They chose to remain agnostic because they want to represent everyone. I think that where physicians are very siloed, and most of us have our heads buried in the sand, and I think we need to recognize that we're educated and we have the resources. We can do more to help represent patients, fight for patients, and other physicians. In terms of quality and value-based care, I mean, I drank the Kool-Aid when ACA was implemented and doing macro MIPS and all these metrics. I talked my group into buying into this because we wanted to provide value, lower cost, higher quality. We did all that. We saved the hospital $2 million. We're a 500-bed community hospital, and we did it all. We led the metrics for the whole operating room, and we kind of tried to do that with all our sites within the Chicagoland area. We wanted to be a very high-performing, reliable organization, and we got to do that. But we're at a point now after the pandemic hit and everyone lost so much money, none of that matters. Because I had relationships with our administrators and we had really great numbers. But at the end of the day, they just wanted to control us. So my goal now is to try to just educate and advocate for physicians as much as possible, and then learn about legislation, and then go to our legislators, and then help Mitch help fight the corporate practice of medicine and enforce the current doctrines that already exist.
Mitch.
Thanks. I'll save some CPOM stuff for the author of the New England Journal article next to me on strengthening prohibitions on the corporate practice of medicine. But I'm going to echo what Eileen said about Medicare being captured. If anyone here supports Medicare for all, that's wonderful, but it's going to be United Healthcare denies care for all at this point. So at this point, I'll just bring up the example where I live in Western North Carolina. There is Mission Hospital, which was a nonprofit hospital, fairly locally invested. So one aspect of this is COPAs and federal enforcement of antitrust. So back in 1996, Mission Hospital being the only tertiary large hospital essentially in Western North Carolina merged with the only other acute care hospital in all of Western North Carolina under a COPA, Certificate of Public Authority. And 20 some odd years later, Mission was bought by HCA, which is the largest for-profit healthcare system in the United States. And there are, I think, like 4 antitrust monopoly suits against them by the municipalities in the area, and class action suits from patients and on behalf of payers at this point. And that's not really, it's not making a difference yet. We're seeing how that litigation goes. At the same time, I wrote the expert report on a False Claims Act, QI-TAM lawsuit by 2 physician whistleblowers. You notice most of us won't speak out. The nurses do speak out a little bit more because they're unionized. We fear for our jobs and our families because we have nowhere else to go. There's no other employers in the area. Even though HCA is not the only hospital in the area, the other hospitals, Duke LifePoint, owned by another private equity firm, Apollo, contract their work out to Team Health, which is Blackstone. So we really have nowhere to go, and that means uprooting families, and especially as physicians are more indebted as we are, younger generations, it can turn into a professional assassination and means that you don't have a future. So that False Claims Act lawsuit against Team Health and HCA was dropped by the feds. So it was unsealed, and they didn't pick it up, so it didn't go anywhere. So complete failure of CMS and essentially the feds on enforcing any teeth in CMS fraud is a huge problem.
Yeah, a couple points I'd underline before talking briefly, hopefully, about CPOM. First, on Eileen's point on unjust enforcement of the Medicare program, particularly Medicare Advantage. Again, it's worth underlining. I think this is a theme here. Recent estimate was that $140 billion per year in overpayments compared to traditional Medicare. Just staggering amount of money. So half of Medicare beneficiaries are now in Medicare Advantage plans. And if we want to ask why big MA plans have the capital to purchase providers, you have your answer in the degree to which the program's just being over-subsidized. So the first ask would be actually just put for a like beneficiary, a risk-adjusted beneficiary, fund the Medicare Advantage program like we fund traditional Medicare. I would also underline briefly Lauren's point about physician unionization. I think that's a really powerful way to begin to combat corporate power, and would note that the point here is not just to sort of raise wages, but just like with any labor union, the point is to democratize the workplace and exert power over critical decision making, particularly by the people whose decisions are important, and those would be the physicians and the other caretakers in the hospital. on corporate practice of medicine, Mitch touched on a lot of this. This is a doctrine, the ban on the corporate practice of medicine. This is a doctrine that's been pretty significantly eroded since the 70s, but has existed in some form in pretty much every state, where either through statute or through common law, judge-made law, courts or legislatures, or actually state attorneys general and even medical boards have basically stated traditionally that medicine is not an industry that should be up for sale, just sort of up to the whims of the market, just like anywhere else, and has essentially said corporations aren't supposed to be engaged in practicing medicine. And specifically, this has meant not owning and employing physicians and not making medical decision making. Since the 70s, we've seen erosion of this doctrine in a number of ways. One is just explicit exemptions, particularly beginning with health maintenance organizations. This is, tracks the sort of wave since the 70s of trying to reduce healthcare costs through managing utilization, and particularly having corporate actors manage utilization in various ways, HMOs being the canonical example here. So we've seen exemptions for certain types of providers. Hospitals now in most states get an exemption. A couple big states like Texas and California actually don't. And then we've also seen through statute, so the main way that corporate practice of medicine doctrine has been expressed through statute is to essentially say that if you're a physician and you don't want to be in a partnership, you want to form a corporation, you need to do so with the majority. You want to form a professional corporation. You need to do so with a majority of licensed physicians. We've seen in a number of states that that law no longer exists. So states have passed laws that basically say there's no longer this majority physician ownership requirement. You can often incorporate as other corporate forms, so LLCs, which tend to be the easiest. You'll see a lot of physician practices now just incorporate as LLCs and not be owned by majority physicians. That's just sort of basically an express repeal. Even if the state courts have said there's a corporate practice of medicine doctrine, if the legislature just says, you can incorporate as an LLC with no physician ownership, that's essentially a abolition of the doctrine. And then the last way, which is probably most pervasive and most tricky from a policy perspective to address, is the way that corporate entities have figured out to sort of contract around the doctrine. This is referred to as sort of the MSO model or the friendly PC model. It's a contracting model that we often see from the private equity world, but is basically actually used by hospitals where this doctrine exists, and also by physician or by corporate owners like United Healthcare. And this is where essentially the corporate entity won't actually own the PC, the professional corporation. They'll own a management services organization, and they'll contract with the PC in such a way to exert functional control over the professional corporation, which may in fact be majority owned by physicians. There's a lawsuit in California right now challenging this because the degree to which some of these corporate owners will use contracting devices such as stock restriction agreements, which basically require the physician to consult with the corporate owner before they, let's say, sell their share, non-competes, gag clauses, and other ways to essentially contract with the professional corporation to exert a level of control that sort of in spirit undermines or subverts the spirit of the corporate practice of medicine doctrine. So there's some legislative ideas bouncing around right now about how to sort of address that at the state level, but generally what was I think much more robust doctrine to ban the corporate practice of medicine is pretty much gone at this point for all functional purposes. And as Mitch said, there's some interest now in thinking about reviving that. A super quick point, I know I'm going too long here. It's worth acknowledging that the CPOM ban has a controversial and somewhat of a fraught history. There's a side of this that is more reflects a professional protectionism that policymakers have worried about. So I think it's really important for when we think about reviving this ban to do so in the public spirit that it was founded on, and that it should be used for.
Can I ask you one more follow-up? Are there any states in particular where it is actually still operational as a law or useful, or is it just completely obliterated?
Yeah, I mean, on the books, it's thought to be more robust actually in Texas and California. So if you're practicing as a physician in California, there are a lot more independent groups. You see a lot more IPAs, and there's not a for-profit hospital actually can't own physicians. I will say, however, there's a bunch of exemptions for that. So the ways hospitals will do this is they'll start like a nonprofit like medical foundation, that will be the owner of the physicians, and then they'll contract with them basically in the same way I just described. So that's basically that the hospital is the MSO and the medical foundation is the PC. I think they also have exemptions for nonprofits. So what we talked about in our New England Journal piece is, despite the variation sort of nominally of CPOM bans, we don't seem to see variation in corporate entrance because there's so many mechanisms by which, frankly, smart lawyers can get around these bans.
Yeah, go ahead. Yeah, Matt.
Just as far as states go, Hayden, I agree. As far as the laws on the book, California and Texas seem to be the ones with the strongest laws. New York is the only place where I'm aware that an attorney general actually took action against Aspen Dental, essentially under the corporate practice of medicine ban. In California right now, we have the AAEM, American Academy of Emergency Medicine, versus Envision lawsuit. And there have been a few private lawsuits that have gone against the corporate practice of medicine, but mostly they've settled out of court. This is a lawsuit that is not seeking any financial damages, and it's seeking a judgment. So there's an effort with groups that I'm allied with, the American Academy of Emergency Medicine, to set precedent and make these, kind of revive the efficacy of these laws. And finally, in Texas, there was a wrongful termination suit against Ray Brovant, who's an emergency physician who was under MCare, which became Envision and all that. He raised concerns about understaffing and dangerous emergency department conditions. He won that lawsuit, but in discovery, they found that Dr. Gregory Byrne was a physician serving as one of those paper owners, a friendly PC, and he had about 300 groups under his name across 20 different states. So aiding and abetting the corporate practice of medicine, a complaint was made against Dr. Byrne to the Texas Medical Board, which has policies on their books about how aiding and abetting corporate practice medicine is not allowed. That complaint was dismissed, and then an appeal was made, and that complaint was dismissed. No investigation. And it's notable that the president of Texas Medical Board is an executive, Sharif Zafran, for U.S. Anesthesia Partners, which is backed by WCAS. And so that might be playing into things. So it gives you a little picture.
Well, that's a perfect transition. Welsh Carson and U.S. Anesthesia Partners for Lauren. You wrote, recently wrote about PE-owned anesthesia and emergency medicine physician practices. I want to get your take on what solutions you see enforcing the current law, and also get your reaction. I mean, you already mentioned it, but the tools that the FTC used to go after Welsh Carson and U.S. Anesthesia Partners in their recent lawsuit.
Sure. So, yeah, I mean, jumping off this last point, I think one piece on the solution toolkit would just be, private companies are going to be clever at hiding any sort of ownership design. So, having some level of transparency about the owners of various companies is useful. Mitchell raises a good point. This is actually one of the ways. So a lot of the work I've done is like trying to map which company, who's the parent company of all the sort of disparate physician groups out there. It's actually one of the ways is a lot of the PE companies share one authorized official for Medicare, basically. So, Envision will have, there's like 3 people across the country for a bunch of Envision groups. So you can just sort of be like, this person's name, if they're IDing that person, that means they are, part of Envision. So they give clues at least. But nonetheless, right, this is something that could be done administratively. CMS could start this sort of tracking on their own. There also was legislation earlier this year, sorry to switch to the legislative side, but it seems that this sort of private equity transparency piece seems to have died at this point. But, again, this is something that could be done administratively. And it's not just private equity, right? You'd also want payer ownership and just sort of whoever the ultimate parent is. I mean, broader antitrust enforcement, I think, is still just like a very key piece of this. A lot of that is, there's still a fair amount of horizontal hospital mergers that sort of clearly cross the sort of guidelines that we know of to think of them as anti-competitive that go unchallenged. And some of that is a resource issue at FTC. Some of that is states don't really do a lot here, even though states have a lot of power to do this. I think that is one thing I would push on state AG offices to take on a bit more challenging here. And there's all this talk about U.S. Anesthesia Partners right now, rightfully so, because they're in the news. But there was a Napa and Mednax, 2 of the, I think, 4 biggest anesthesia providers at the time in 2020, merged without a peep. right? And that sort of created a huge conglomerate. I think in the work we did in Newark, New Jersey, and Arlington, Virginia, for instance, that merger created over 70% combined market share for those companies. And right, that seems to me like that probably should have triggered some alarm bells as a potential antitrust complaint. But again, sort of went through quite smoothly. So I do think, and again, the legislative, it's hard to avoid too much. Some of this is, the antitrust rules on the books. It takes it's very resource intensive to win these sort of lawsuits. So legislative changes could sort of reduce the resource intensity here, which I actually do think is important. The U.S. Anesthesia Partners complaint is interesting, right? Because part of this is they've got some, allegedly have some kind of smoking gun sort of things. Right? Agreeing to split up markets between two companies is a little bit more, right? If you've got email traffic proving that's a little bit more kind of smoking gun-esque than just broadly we consolidated and raised prices. A lot of the quotes are just like, we consolidated in order to raise prices, and honestly, I don't need someone's quote to think that's why they're doing that. That's just sort of like, that's Econ 101. That's sort of obviously, that's at least one of the reasons, maybe not the only one that they are doing that. But it is an interesting complaint because this sort of roll-up strategy that they're talking about where, U.S. Anesthesia Partners started in Houston, for instance. They bought Greater Houston Anesthesiology as their sort of platform company. That was already a big company. I think it was 30% or so of the market at least in the Medicare market is the way we've looked at it. But they grew that to 70% of the market through a ton of smaller acquisitions. Did something similar in Colorado. That is a very common model. They're not the only one who did that. So it does raise this, I think, interesting question about, are there more complaints coming down the pike? And how much is it really, we need to see the lawsuit play out to some degree as well, because how much is it just sort of the smoking gun emails? This is like all fraud cases in general, the sort of, again, like complaints against CMS winning fraud cases. Again, it's like a lot of times you really need that, emails, traffic between people on like colluding over generic drug prices and things like that that you need that kind of like real proof to win some of these. I will just sort of, I think I would touch one more. I think a lot of people have sort of brought this up already, but in Medicare Advantage, I think in my eyes, a key reason for a lot of the payer acquisitions that we are talking about, when you're talking about United, Humana, CVS, Aetna, a lot of those acquisitions, I have to imagine, is driven by being able to see your Medicare Advantage enrollees and being able to send nurse practitioners or whoever to their house to sort of mark down every condition they have or ever will or ever have had, because that is how you get paid in Medicare Advantage. You get paid for how sick your enrollees look on paper, and that is a huge incentive. And sort of, we have evidence even from the sort of the Kaiser type of entities that having that vertical integration sort of allows you to kind of code up your patients more intensely. So I think some of this is sort of United, Humana kind of catching up to some of those hospital-based insurers to do some of the same. And right, that is where like there is just a lot to be done on fixing risk adjustment. There is a lot, like this is one thing CMS is sitting on the authority. They can at least do across the board cuts on these what are called coding intensity adjustments. They're almost like, jargony name ever. But basically they can just cut payments across the board to Medicare Advantage plans to adjust for the fact that we know that basically the patients are not as sick as they actually look in Medicare Advantage, but are not doing that. So that is sort of sitting on the table at the ready right now. So I would sort of suggest that. I think just one point that I don't think it's raised enough in the Medicare Advantage context, and it's maybe not directly tied to like coding per se, is just a big part of why Medicare Advantage is so popular nowadays is because the traditional Medicare, your sort of like standard public program here, the benefit is lacking, right? It does not have a maximum out-of-pocket limit on how much you as the consumer can owe in a year. That is very hard. I would never enroll myself, especially me as a 65-year-old or older, I would never enroll myself in something that has uncapped liability. So you are then forced to buy one of these private supplemental plans that cost like $200 a month, sort of on top of your Medicare. So that and kind of other, it's like a non-integrated plan. Some of it, the cost is like there's no prior auth or anything like that. That sort of pennies are going to like a little bit more. But really kind of sprucing up the traditional Medicare benefit, I think actually goes a long way to providing an actual real competitor against sort of the Medicare Advantage plan, sort of to kind of put things more on an even playing field.
Hayden, you have a comment? Or so One thing that you also have seen out of the FTC, and you've seen it out of some states like California that have unfair methods of competition authority. Do you see anything that, related to the, corporate influence in medicine that could be, any of these tactics that could be, we would consider sort of ripe for unfair methods of competition? I mean, they already have a rulemaking banning non-competes, for example, which has been brought up as a problem. Anything else? Anyone thought about Section 5 at all, or those types of authorities? No. Oh, yeah, go ahead, Mitch.
Well, okay, I'm not an attorney either. I've looked at that in relation to the AMA, and I think I'll actually save that one for a little bit later. But as far as anti-competitive behaviors, essentially, I think what we're seeing a lot, and I think is under discussed, is the anti-competitive behaviors towards labor. And so in relation to the non-competes, that's an important one. Again, the AHA opposes that for physicians as if we are like have all this power, and I think they're remembering back from the 50s, and that's not really the case anymore. One big issue is a lack of due process for physicians. Essentially, if a big hospital system wants to get rid of a disruptive physician, someone that advocates for their patients and disrupts the process of profiteering off of them, then we can be fired immediately without any recourse at all. So when the hospitals contract with a third party, like a private equity-backed contract management group, the federal requirements from Medicare for due process rights, basically due process to our ability to work, are completely bypassed. So those third parties are not subject to those federal requirements. There is a bill, the ER Hero and Patient Safety Act, which has been introduced that would extend those due process rights to physicians. But we go a little further than that, and this was the the Healthcare Quality Improvement Act from 1986, which essentially established the National Practitioner Data Bank, which was the idea that you could report a dangerous physician, which is an important concept. But there is broad immunity for hospital corporations to report a physician. And so that's a big opening to retaliate against a physician. They don't even have to prove anything, just report it. There's an example of that, again, physician on HCA Mission who had a bad outcome in surgery. He was cleared by the Medical Executive Committee and the North Carolina Medical Board, but HCA placed a complaint against him, and even after he was cleared, still there on his record, can't get a job. So the power that these corporations have over physicians to say, jump, and we have to say how high as far as the practice of medicine goes, is really untenable.
One thing, and then I want to open things up to the floor for questions, but getting back to solutions, the flip side of corporate influence in medicine in some ways is a commitment to independent medicine. A lot of healthcare laws seem, at least, over the past 20, 30 years, seems to be sort of derived from a bit of a, I don't know how to describe it, but like kind of this like neoliberal kind of nanny state type of, we can be more efficient, we can do things more efficient, we can be more centralized and get these better outcomes. And it actually kind of discourages independent medicine, as we talked about, kind of incentive to consolidate and have this vertical integration. That's, I think Hayden mentioned, it's kind of the result of the laws that have been on the books. And so, from an ideological standpoint, from a policy standpoint, how do you advocate for the value of independent medicine, and how do you want policymakers to start thinking about that as an important solution here? I mean, we've got a lot of independent medicine experts. I thought that could be a good topic of conversation. Eileen, do you want to start? Or?
Yeah, well, I'm going to say something different
Okay.
because I'm not a doctor. I haven't been involved in that. I was very much involved in the ending of the surprise medical bills. And the lesson I learned from that is to see where you can shut off the money hose, because Envision is out of business. Team Health and Blackstone are negotiating with their creditors. Getting rid of the surprise medical billing has really put a hole in that model. They're not able to do what they were able to do. It's not profitable anymore, and I don't know what's going to come after, but there's an opening here. And at least we don't have to worry about private equity taking up, they're not buying doctors' practices in hospitals anymore. They've expanded to doctors' practices outside of hospitals, but the hospitals are not that attractive to them. And I think that's what we're doing. We're looking for where is the money hose? How do we make them work for their money? They don't want to work for their money. So if they have to work for their money, they're going to go someplace else, is what we think. There's a group already working on this in Medicare Advantage. As I say, that is a really complicated one to explain to the public. Nobody is doing a good enough job there letting the public know that the way that Medicare Advantage provides all those goodies that it provides is by taking advantage of the system, overcharging, and then sharing a little bit of that with the. They don't want. If you have expensive things that you need taken care of, they're not in for that. There you have to get the pre-approval, and there we know we have a lot of denial. But you want to join a health club? Hey, we can let you do that. And for poor people, as Lauren pointed out, there's no alternative, because there are plans in Medicare Advantage that have zero or no premium, and there's a cap. There's an $8,300 cap on out-of-pocket in any year. It's a little high, but still it's capped, whereas it's not in traditional Medicare. So yes. I think we need to think about how do we modernize traditional Medicare, and one of the things that, not my idea, but this group that's working on Medicare Advantage has come up with, and that's Medicare Part E, which would be a low-cost or no-cost wraparound. All the middle-class people already have it. All the poor people have to be in Medicare Advantage because they don't have it. And people who are healthy or think they're going to be healthy until they're 90 move into Medicare Advantage, and then it becomes impossible to switch. You can switch every year back to regular Medicare, but the wraparound plans don't have to take you. They're private insurance. So you're sick, you need a lot of care, there's no cap, and you're not eligible for Medicare wraparound. So closing those kinds of, making Medicare itself more attractive, how they get to call themselves Medicare Advantage. Suppose when you turn 65, they said to you, you can have a Humana insurance policy or you can have Medicare. I think the choice would be clear. But if you call it Medicare Advantage instead of Humana, people don't really understand it. So more has to be made to let taxpayers know they're being ripped off. That when you really need care, it's like any other insurance company. When you really need it, forget it. As long as you're healthy, they're the best insurance company you can imagine, but after that, not so good. So letting people know, letting them know what the downsides are, because these are not advertised, and letting them know that, yes, you are getting a health care benefit or you're getting a vision benefit, but this is at taxpayer expense, at the expense of the trust fund, and in terms of what you will be able to get in the future, it's very troubling.
Mitch, anything to add on that?
Sure, to the question about the independent medicine.
Yeah.
I'll follow up to what Eileen said about the turning off the hose and making it less profitable. I think that is a piece of it. I read a McGuire Woods law firm report on private equity trends in medicine, and emergency medicine was less, and because essentially the No Surprises Act and the EM lawsuit. They're a little afraid of jumping in those waters. Some sporadic CPOM stuff here and there, and then less in terms of finances. The problem is, I think, these private equity firms are in there to squeeze whatever they can and then get out, and they'll go through a couple of rounds if there's more to squeeze and bite out of the apple. But while they're doing that, they're draining the whole thing of life. And so what we have is a bunch of collateral damage at the end of it. HCA just announced that they failed to meet some profit goals in their joint venture with Envision, which is bankrupt. Well, what's that actually going to do? They're going to cut services more in the ER. They're going to replace more physicians with non-physician practitioners with lesser training. They're going to understaff more, probably pay less, the whole 9 yards there. So we're not out of the woods. We got private equity out, but they did an awful lot of damage, and it's still leading to this vertical consolidation. An example with USAP, I think it's just a good place to look at, is after the No Surprises Act went through, U.S. Anesthesia Partners' sister analogous group, which is U.S. Acute Care Solutions, was alluded to in the lawsuit with the Federal Trade Commission, they didn't name them by name, but they said the same thing. They did the same thing in emergency medicine. That's USACs. 1 month after the No Surprises Act was implemented, Apollo Global Management essentially divested, or excuse me, WCAS divested from USACs, and that group put on this huge campaign that said, "We bought back our group. We're physician owned." They did that with a 10.5% interest loan in the neighborhood of $711 million to Apollo Global Management, and then put a couple of their executives on the board and said, "We're physician owned." So, and this kind of debt is something that if they fail to pay back in 2026, is owned by Apollo again. So we're seeing this kind of disaster in that regard. And we've got some other ideas on physician independence, but I'll.
Okay.
So a couple things with private equity leaving a vacuum. That's happening in our market as well. We had Envision in a sister hospital, and they were asking for a subsidy from the hospital. The hospital refused, so they left, and then another one came in. I think that in our market, they're not going to private equity anymore. This is where I said hospitals are basically just rolling up groups now, so taking over, trying to employ them. And I think in terms of trying to stay independent, it's not going to come from the top down. That's where we're trying to educate other physicians and trying to get them to realize that we can be a part of the solution, and trying to bring everyone together, uniting all these grassroots efforts, bringing more attention to the established societies. And I think that's pretty much it.
Okay, great. You have time for 1 or 2 questions?
I don't have a question.
Oh, do you want to come up to this mic, if you don't mind?
I'm Kathy Kelly. I'm an ER physician from Northern Virginia, and I just have always had an interest in all of this stuff. But I just wanted to add on to what Mitch said about USACs, because I'm local to the area. I don't know who is local, but USACs has right now a monopoly on the ER. After Lauren was mentioning about, was it Texas? USACs has monopolized almost all the ERs in the Maryland, circling DC, and Northern Virginia. Fairfax Hospital, Arlington Hospital, Alexandria Hospital, Reston, Shady Grove, Holy Cross, they have them all. So they'll be able to set prices, and it's not good. They don't have non-competes for the physicians they're taking on because they don't need to. They have the doctors who want to stay local have no other place to work. So that's all I wanted to say.
Yeah, you should. I think the FTC mentioned the Welsh Carson's emergency medicine in their lawsuit. So, as Mitch mentioned, so you might have an outlet for your grievance. Well, any other questions? All right. Well, thank you so much. This was a really, really interesting conversation. We covered a lot of ground. Thank you.